Hi, I'm Dr. Jason Wagner with Sarasota Vascular Specialists, and today I'm here to talk to you about what we do if your dialysis access fails. Specifically today, I'm going to talk about what happens when your fistula shuts down or if your graft shuts down. If you have a fistula, that's a connection between the artery and the vein is what's being used, and this shuts down or is having problems, there are two types of failure. There's functional failure, meaning it's still up and running, but it's not good enough or it's not working well enough. It might be high pressure, or it might be that it's not getting enough flow at all because it's completely shut down and quote unquote clotted off. If a fistula has shut down, sometimes we can go in if it's completely shut down and make a couple of small needle pokes, get into it, suck out all of the clot, find whatever the narrowing is in the outflow and get it open. If, however, it can't be fixed, then we need to get you a different way of getting dialysis. And that's usually going to be coming higher up the arm to the next available vein that we can connect to make a fistula. As a temporary way of getting you dialysis, if we can't get you your fistula up and running, we would give you a temporary catheter in the chest, and then as quickly as possible, get you set up for surgery to get you your next durable hemodialysis access in the arm, be it a fistula or a graft. If it's a narrowing in the vein that's causing a problem and your fistula is still open, what we'll do is we'll make a small poke, usually where the artery and vein connection is, we call the inflow side, where flow is going into the vein or into the fistula. We'll get a wire through the area of narrowing and we'll balloon it open, we'll stretch it open. If it keeps trying to shrink back down after we balloon it, sometimes we'll have to put a stent in to hold that area of opening. The most common areas we see a kind of narrowing in what's called the cephalic vein fistula is either right at the arterial anastomosis, right where the vein is sewed onto the artery. And so for that, we'll actually stick and go backwards down towards the artery and balloon open the area where the artery and the vein are connected. Otherwise, if it's in this area called the cephalic arch, we'll get a wire through there and balloon it open. And if that doesn't stay open, then we'll use a stent to hold that area of the vein open. If your graft, which means you have an artificial vein, isn't staying open or it's shut down, and so say you have a graft going from your brachial artery right here to your brachial vein up here, if that's shut down, that means this section is not going to have any blood flow. Usually that happens because of a narrowing right there at the venous outflow. The vein's not used to getting this kind of blood flow going through it. Sometimes it spasms down, gets some scar tissue in it, and it starts to shut down. If we can catch this before it completely shuts down, similar to when we treat a fistula, we'll access down here, we'll get a wire through it, and by accessing, it's a small needle poke. We get a wire through it and balloon that area open and or stent it if we need to. That's done usually under a little bit of local anesthesia and some sedation if needed, sometimes just under local anesthesia and that's it. If the whole access is shut down, meaning that the narrowing in the outflow has actually been so bad that not enough blood flow is going through it and the graft quote unquote clots off, that's okay. What we'll do, similarly, we'll access here down by the arterial inflow. We'll get a wire and a catheter into it and sometimes use some special devices to suck out and get rid of all the clot in the graft. And then once we've cleaned it out, we'll get a wire through that area of narrowing in the outflow. We'll balloon it open or stent it and fix the thing that caused it to shut down. We call it the causative lesion. And once we've done that to clear the outflow, we'll do a second little poke up here, come down towards the arterial anastomosis and get the little plug of clot that's right by the artery, pull that out, make sure that's all taken care of and open and you've got flow reestablished in your graft. And then we usually put a tiny little stitch at the skin at each site where we go in, and then you can go back to dialysis that very same day. So I'm Dr. Jason Wagner with Sarasota Vascular Specialists, and that's how we kind of quickly and easily in the outpatient setting treat a problem, be it a narrowing or a complete blockage of your dialysis access. If you have any questions, comments, or thoughts, please feel free to reach out or leave a comment below.